So good morning everyone. Uh, Welcome to this next instruction course which is on how to settle this retinal detachment, and in this course we will be discussing practical guidelines for the various surgical procedures and treatments available in retinal detachment. So we'll have talks ranging from lasers as a prophylaxis to pneumatic retinopexy to scleral buckling, then vitrectomy, and we have a star-studded panel of retinologists who will be dealing with all these various aspects of RD management. Uh, Without delay, I'll call the first speaker, and that is Dr. K.S. Kumar, and he is going to deal with two topics. First is how does laser photocoagulation work in retinal detachment, and what are the practical tips of pneumatic retinopexy as one of the management modalities. Dr. Kumar, sir.
Thanks, Dr. Preetam, and I would like to thank you for including me as part of this instruction course and the AIOS for selecting this instruction course. I have tweaked the title a little bit. I'll go with how practical is pneumatic retinopexy first, and then talk about the role of lasers in management of fragmentogenous retinal detachments. I suspect that Preetam himself was a little critical about the role of pneumatic retinopexy when he designed the title, when he put it as how practical is pneumatic retinopexy. I won't be going into the details of, I won't be dwelling anything about the steps of pneumatic retinopexy, but I would like to, present a present perspective of pneumatic retinopexy, which has somewhat had a roller coaster ride so far, a checkered career if I can say so. So it's a minimally invasive procedure, as we all know, for non-incisional, uncomplicated, so there's something which is coming here. Somebody is operating from there. So it's a minimally invasive non-incisional procedure for repair of uncomplicated RDs, and the mechanism of action is too well known for all of us to reiterate here. There are specific indications for pneumatic retinopexy and specific contraindications where the procedure doesn't work. We are all aware of these various situations, and also we are aware of cases which are ideal, some which are unsuitable, but we may have to seek recourse to pneumatic retinopexy in exceptional situations, and some where it is possible to do pneumatic retinopexy. So to come back to the topic of how relevant or how practical pneumatic retinopexy is in this era, it's now the focus has shifted from a single operation anatomic reattachment rates to functional success. Now we are no longer looking at anatomic reattachments, we are looking at functional success, where we are calibrating the visual acuity, presence or absence of anisoconia, metamorphopsia, and vision-related quality of life indices. And we are now basing all our thoughts on evidence-based medicine as well as the newer multimodal imaging techniques, which have shown us that the reattachment is not just an anatomic reattachment, but also we are looking at the finer aspects of that reattached retina in the form of outer retinal folds, persistent subfoveal fluid blebs, and retinal displacement as seen on autofluorescence imaging and integrity of the ellipsoid zone, etc. All of these are imaging biomarkers for a reattached retina, and autofluorescence has shown us that there are two types of retinal reattachment that happens: a low integrity retinal reattachment and a high integrity retinal reattachment. We will go through this in the next few slides, and it has clearly shown that the RPE, which was hitherto covered by the retinal vessel, now whenever there is a displacement of the retina after reattachment, that zone which was hidden by the retinal vessel now gets exposed to light, and there is an alteration in the composition of the fluorophores and metabolic composition of the RPE, and you see what is called as vessel printing, and this is the cause for the various visual quality of life post reattachment. This is what we were discussing. The retina may reattach. The retina may reattach post-surgery, but it's displaced in terms of its clock hour position, and that is what, Now that is what is seen as hypofluorescent lines, the vessel markings on autofluorescence imaging. So the pneumatic retinopexy has been clearly evaluated in the pivot study, where patients who underwent pneumatic retinopexy had better best corrected visual acuity, less vertical metamorphopsia, less incidence of morbidity in terms of cataract, and better mental health and vision-related functioning scores. So that is a randomized double-blind trial which has clearly proven the role of pneumatic retinopexy. And also with swept source OCT, Pneumatic retinopexy has shown elegant figures where several 5 stages of reattachment of the retina has been depicted as to how the retina reattaches post pneumatic retinopexy. It's an outside in, where the RPE pump is relied upon, contrary to inside out as we do in vitrectomy and a fluid air exchange, where there is high surface tension, high buoyancy, and that can cause what we just discussed in the form of retinal displacement. Whereas the retinal displacement does not happen with pneumatic retinopexy is what these sweat source OCT studies have shown. What is seen is immediately after the gas injection, there is an increase in the subretinal fluid, and then slowly progressively over a period of weeks, there is the reattachment, and then the development of there is initially this subfoveal detachment, and that settles over 6 to 8 weeks. Elegant OCT pictures that are seen post pneumatic retinopexy. So eyes with pneumatic retinopexy have lower incidence of all of the retinal morphological changes as compared to vitrectomy or a scleral buckle. And now there is talk of minimal gas vitrectomy, where there is no fluid endodrainage done at all. There's vitrectomy done, and if there's an associated inferior break, a buckle is put, and it is a pneumatic retinopexy at the end of the procedure, partial filling with gas, and that is thought to result in better visual outcomes. Even modified scleral buckling techniques have been advocated now, where there's no localization, cryo or SRF drainage done. There's only, everything is based on the preoperative assessment. A buckle is put in the quadrant of the tear detected, and paracentesis is done, and intravitreal gas is put. So the focus is shifting even in vitrectomy to minimal gas vitrectomy, not a complete fluid air exchange and gas. So pneumatic retinopexy, there is objective evidence to prove that the type of reattachment that it attains, that it gets for our patients is much better than that achieved by vitrectomy or vitrectomy or scleral buckle. So these are some of the situations where pneumatic retinopexy can be elegantly employed. And as a secondary procedure, as we are all very well aware, recurrent superior RDs where we can't identify the causative break or ill-supported breaks, or RRD after vitrectomy and sclerotomy related breaks. As extended indications, some of these are also in the list. So these are some pictures which show this is a patient who had a pneumatic retinopexy for an upper temporal macula on RD with good results. Successful pneumatic retinopexy for RD that developed following macular hole surgery. This is what is called as a secondary pneumatic retinopexy, or as a rescue procedure in non-settling RD after scleral buckle, we can employ pneumatic retinopexy. These are some of the extended indications with the schematic diagrams used only in exceptional situations. This is a case which developed almost a giant retinal tear following 20-gauge vitrectomy years ago, and we were able to successfully do sequential pneumatic retinopexy and settle that retina. So pneumatic retinopexy is a friend in need of the vitreoretinal surgeon. We must be willing to do what the retina in question is asking of us, and not do what we know. So a particular retina will be asking for a certain procedure that needs to be done, and we must be willing to be aware of all the options available for that case, and then duly employ that particular procedure, what is referred to as the horses for courses policy. Now, I leave you with this thought. Pneumatic retinopexy is inexpensive and therefore unpopular, or is it inexpensive and therefore unpopular? So we go on to laser photocoagulation in rhegmatogenous retinal detachment. Now, the history of lasers in management of retinal detachment dates back to 1968, when Okun and Sibis first employed employed laser photocoagulation in specific situations, as you can see there. As we all know, it's not a definitive treatment, but can be an expectant therapy to wall off or demarcate or sequester the area of detachment from the rest of the retina as sort of quarantine. May be employed in apprehensive, infirm patients or poor surgical candidates, unwilling for definitive therapy, or lack of resources that may be either financial or medical. So those are some of the indications where we may be able to successfully get away with doing just laser photocoagulation. This is a patient with a peripheral retinoschisis related detachment, or a subclinical retinal detachment in the periphery, where we do overlapping burns, partially overlapping burns, and leave no spaces in between 2 to 3 rows, as the traction is thought to extend beyond the margin of the detached retina. These are some of the situations where we may be able to wall off the inferior detachments. So the limitations are that it's a stopgap arrangement, and counseling is vital, that the patient may need a definitive procedure. There is no well-defined criteria about indications. There are issues related to treatment per se in the form of field loss and epiretinal membrane formation, full thickness macular hole formation, etc. Constant follow-up is needed, but even so, it's a simple, time-efficient OPD procedure, inexpensive, and it doesn't need any really trained personnel. Even those with basic knowledge in medical retina can do the lasers in specific situations. Observation versus laser, the role is not proven really. Remote areas with poor access to medical care or underserved areas, some degree of additional protection may be afforded by laser in these situations. And rare instances of reattachment have also been described following laser, where the PVD that occurs post-laser, the vitreous itself plugs the brake and the retina may attach. So those are some of the fortuitous cases, chance occurrences. Lasers after retinal reattachment, of course, we do employ post-scleral buckling, post-vitrectomy as an endolaser procedure, post-pneumatic retinopaxy also many times where cryo is not employed in the initial steps of pneumatic retinopaxy. We may reattach the retina and then do laser after the retina is attached by making the patient's head turn away and move the gas away. Transscleral diode retinopaxy is also possible through buccal elements. So these are some of the situations where a shallow peripheral RD can be delimited with lasers, or an inferior RD where we now wall it off with laser. Angioma-like lesions, whenever there is a heavy photocoagulation done, has been described. This is from the literature, and I would conclude with this last slide. Thank you so much for your patient hearing.
Thank you, Kumar. As usual, it's an excellent presentation with a different research and outlook. I'll now invite Dr. Preetam Samanta to give his talks. Any questions? Acha. Dr. Kumar is leaving. Any questions anyone would like to ask? No, please go ahead.
I'll go ahead. Okay. So, we started off because Dr. Kumar has to be excused, so we started off. So, without introducing all the panel for this course. So, I would like to invite and acknowledge the presence of Dr. Amit Kumar Deb. He's a professor of ophthalmology and retina from JIPMER, and he's going to give later on a keynote address on anti-VEGFs. I would like to invite Dr. Ashish Vaidya, Dr. Vatsal Parekh. The other two faculty who are going to join us is Dr. Nishikant Borse and Dr. Nitin Prabhu Desai. So I'll start with my presentation, and that is vitrectomy in retinal detachment. So we saw the importance of laser and pneumatic retinopaxy. And now let's dive into straight away vitrectomy in retinal detachment, principles and techniques. It's a big topic, but I'll try and do justice in the next 8 to 10 minutes. So my presentation is divided essentially into 3 parts. What are the indications of vitrectomy in retinal detachment? What are the principles behind achieving success, and the modern vitrectomy techniques and how they've changed our success rate? So indications, when do we opt for vitrectomy versus procedures like pneumatic retinopaxy and scleral buckle? First of all, when there is PVR, because if PVR is going to decrease the success of retinal detachment, then you have to get the PVR, the membranes out. There you need to do a vitrectomy. Retinal detachment with accompanying pathologies like, say, vitreous hemorrhage, macular hole, intraocular foreign body, giant retinal tears, or probably a complication of cataract surgeries. In these situations, you are compelled to resort to vitrectomy. In the sutureless vitrectomy area, we have now changing, we are becoming more aggressive towards vitrectomy because the rehabilitation with sutureless vitrectomy is much better. You want to have lesser amount of red eyes, post-operative edema, proptosis. So probably for cases like, let's say, a superior localized retinal detachment with a single break, which can be buckleable, and pneumatic retinopaxy can be done, but you could get away with a sutureless vitrectomy also because the rehab will be fantastic. So this is debatable. This is an age-long debate. You can always debate because both will work in these situations. So principles of achieving success. The first cardinal thing is Pvd induction, and what helps us in Pvd induction, there you can see the nice Weiss's ring. Now this case already has a Pvd. You can see the retinal detachment behind. And to achieve Pvd induction, we use triamcinolone, and we can apply active or passive suction at the edges of the disc a forceps sometimes can be used to induce a posterior vitreous detachment. Now you can see here, you have to be very careful, use low suction, high cutting rate, because the detached retina is right behind, and the PVD has been induced and the vitrectomy has been started. Another one more thing you can use when you're doing this maneuver is put a small bubble of PFCL on the posterior pole of the disc. So it acts as a third surgical hand, and you can do this same vitrectomy or core vitrectomy to start with. The most important thing in vitrectomy for retinal detachment is to do a complete vitrectomy. The rationale being that you don't want residual vitreous remaining behind, because that residual vitreous will act as a scaffold for PVR and will cause a recurrent detachment and will bring down your success rate. So therefore, to achieve complete vitrectomy, you also need to do base excision. Base excision is very easy in maybe aphakic RDs or in pseudophakic RDs. But when it's a phakic RD, sometimes it may be difficult, because at the time of base excision, you could end up having a lens touch. The other place where complete vitrectomy is a challenge is in pediatric and young RDs, young patients with RDs, because over there you have a lot of vitreous, and that vitreous is firmly adherent to the retina. The other important thing is flattening or settling the RD, settling the retinal break. That has to be the endpoint of a retinal detachment. You do that with fluid air exchange. If there is intrinsic contraction and your fluid air exchange is not able to attach the retina, this becomes obvious because the air goes behind the retina. In that case, you have to do a relaxing retinotomy to settle or attach the retina. Now, one has to remember that there is really no need for a bone dry subretinal fluid drainage. Once your peripheral retina is attached and your retinal breaks are attached, you could leave back some amount of fluid at the posterior pole, because once you put a tamponade, this residual fluid will get absorbed by the retinal pigment epithelium in the postoperative period. Then doing laser and cryopexy to all the breaks, and this is done after you've done a fluid air exchange before inserting the tamponade. The various tamponades that we use in retinal detachment, the PFCL, which is essentially a temporary tamponade. You can't leave PFCL for many days after the surgery because it is toxic to the retina, but it acts as a fantastic third surgical tool where it keeps the retina absolutely stable, keeps the retina back, avoids iatrogenic retinal breaks. In a case like this is a high myope with a giant retinal tear. You can see the retina is rolled over here. We are doing a vitrectomy, and to roll this flap back, PFCL becomes very important. You can see the PFCL bubble being put there, and gradually as you fill the eye with PFCL, the giant retinal flap rolls back. I'm using an instrument to roll the rolled over edge of the giant retinal tear, and once the giant retinal tear will flatten, then we do laser to the edges of the giant retinal tear. Now this is the end of the surgery where you are removing the PFCL while injecting the silicone oil. That is called as PFCL silicone oil exchange. Finally, once the tamponade, the permanent tamponade, you can either use a gas or SF6 in these RDs, or a silicone oil. That is the permanent tamponade, and you do a post-op prone position. The other aspect is whether to put a band or not to put a band. So this is also a debatable thing. When I use a dictum when I'm not happy with the amount of vitrectomy that I've done, when I've left a lot of vitreous in the periphery, in that situation I usually tend to put a band. Unlike in situations where I'm absolutely sure that I've done a complete vitrectomy. If I'm seeing a lot of PVR and I'm leaving some residual PVR back, there probably I would put a scleral band. If it's an inferior break, because there will be a potential space between the oil and the retina at the 6 o'clock position, there I'll put a band. So these are some of the situations where I put a scleral band or a 240 band along with doing a vitrectomy and tamponade. What has changed the success rate is the sutureless vitrectomy, the high-speed cutters. Now this has made rehabilitation much better. So the advantages of sutureless vitrectomy, where you have a trocar cannula system. Now this is a video from olden times, from 15 years back, where we made these 20 gauge sclerotomies, and at the end of the procedure we had to clear the vitreous from the sclerotomy to achieve a free flowing sclerotomy. If you didn't do this, then you would end up with iatrogenic breaks. You could have sclerotomy related complications like this. Now what you're seeing here is a retinal break right at the sclerotomy site. This is because of retina getting incarcerated into the sclerotomy, and now I have to tackle that, do fluid air exchange, cryo that retinal break. So these would definitely bring down the success of the surgery. So what you have now is these trocar cannulas, which you insert at the pars plana, you displace the conjunctiva, you insert it, and this gives you a nice clearance, because the inner tube, the inner part of the cannula is quite long and it easily traverses the vitreous base. You have valve trocar cannulas also, which like this is a valve trocar cannula, and the advantage here is this does not allow intraocular hypotony, because you're always worried about intraocular hypotony when you're removing your instruments and putting them back inside the eye. So these valve trocar cannulas also have made life much easier. Like I said, high speed small gauge vitreous cutters, high cutting rate has decreased the surgical time. There are now cutters where the tip is absolutely at the end of the cutter, and that becomes very easy to shave the vitreous, especially from when you're doing vitreous base excision. Another concept which has made life easier is the concept of duty cycle. So what is a duty cycle? Now the duty cycle is, as shown in this animation, is for the same cut rate. Now you can see here, for the same cut rate, this is open for a longer time and this is open for a shorter time. So this becomes a lesser duty cycle, whereas this is a maximum duty cycle. So in the next, you'll see now, you see here, this is used for core vitrectomy, where you want a lot of cutting and suction to happen. You can see how agitated the vitreous is. Whereas this is for shaving the peripheral vitreous near the retina or base excision, where you see how steady the vitreous is. And now actually inside a case, this is a core, into the core mode, where you can see how mobile the retina is. I'm using the core mode to cut the vitreous over a retinal break, and you can see how mobile the vitreous is. But when I shift to the shave mode, there's a shave mode, I'm doing the same maneuver at the same site, and you can see the retina is hardly moving. So these are the kind of techniques which have changed the success rates. So modern vitrectomy, you have better illumination nowadays, you have chandeliers, you have wide angle viewing systems, there's chromovitrectomy, better tamponades, better instruments. So the chandelier also helps in certain situations. Here's a case where I use a chandelier, because this was a case where there was an intraocular foreign body which was impacted in a detached retina. Now if I were to yank off the intraocular foreign body from the retina so close to the posterior pole, it would have caused devastating complications. This is my last slide. It would have caused devastating complications. So instead I put a chandelier, you saw me putting the chandelier, and I'm using bimanual, a forceps and a scissor to detach this IOFB from the retina over here, get the intraocular foreign body out. And you can see the foreign body being removed. This is a bubble of PFCL I've put on the posterior pole to keep it safe. There's the foreign body coming out. I've extended my sclerotomy, removing the intraocular foreign body. And then I tackle the remaining retinal detachment by doing laser and putting silicone oil. That's the huge place that, where the foreign body was impacted. So this is the kind of success we achieve with these modern vitrectomy instruments. That's the end. Thank you.
Thank you, Preetam. Any questions for Preetam? I would now invite Dr. Nitin Prabhu Desai for his talk on sterile buccal indications and techniques for retinal detachment.
Good afternoon, everybody. Now, actually, the sequence was going from simpler surgery to the difficult surgery, but Preetam has already shown you the difficult part. I'll be looking at
I think it's gone the right way, because today we do more vitrectomies than buccal.
Yeah. So, when you have a... can I have the pointer, please? Excuse me? Pointer is there? Okay, so when you have this partial RDs with a single break, or again a single break partial RD, then doing a scleral buccal gives good results. Next, this is a first day picture post-op, when the breaks are on the buccal, retina is nicely flat. 1 month post-op, again the retina is nicely flat, no problem. Even if you have multiple breaks but in a single quadrant partial RD, again scleral buccal works well. So scleral buccal is definitely a good thing to do when there is single or multiple breaks in one quadrant, absence of significant PVR, young phakic patients where doing vitrectomy is also difficult, aphakic patient with well dilating pupil and clear vitreous, and pseudophakic patients with well dilating pupil and clear vitreous. So if you have such conditions where multiple breaks, rolled edges, this is not a good one for buccal. If you are already PVR, not a good case for buccal. and extensive PVR absolutely contraindicated. Giant tears absolutely contraindicated. So scleral buckle has a role, but not in all cases. That should be very clear. And how do you go ahead with this complicated cases? We have just seen with Preetam what to do in those cases. Now, if you are looking at scleral buckle, the most important thing in this situation is to have a dilated indirect ophthalmoscopy, because that is the heart of the scleral buckle surgery. Half the surgery is done before you go to the OT, because if you know the breaks, if you know the extent of the RD, you know where to treat, then in the OT it's just like a carpenter's job. Having a proper detailed drawing, again, why it is important to have a proper detailed examination and drawing is that you can plan your surgery very well if you have a proper drawing, because sometimes what happens, you go take the patient to the OT, the pupil goes down, the cornea becomes hazy, and you don't know where the break is going and how to treat. But if you have a plan like this, and if you have a drawing like this which shows all the details, you can sometimes maneuver in the OT and have a success with proper closing of the breaks. Usually the surgery is done under local anesthesia, and sometimes in anxious patients with local and sedation, and in children under 15 and adults who are really claustrophobic, we may have to give general anesthesia. Now I'll just go through the steps quickly. The first step is to perform a good conjunctival peritomy 360 degree, and you give a relaxing conjunctival cut so that the retina doesn't, the conjunctiva doesn't stretch when you're hooking and moving the eyeball around. And once the conjunctival peritomy is complete, you separate the tenons and the intermuscular septum with a blunt tip scissor going back up to the equator. Then you start hooking the muscles. The sequence is usually the inferior rectus, then the two lateral recti, and then the superior rectus. Once the muscles are hooked, you start passing a suture so that you can maneuver the muscles all around. Once the muscles are well maneuvered, you inspect the sclera. That's very important, because if the patient has a scleral ectasia in a quadrant where you want to put a buckle, then that becomes a contraindication for going ahead with that surgery. So this is a rare situation that you have to change from a scleral buckle to a vitrectomy on table, but if you have a very significant scleral thinning, you may have to do that. Now once you have dissected the muscles and hooked them, then you look at the break with an indirect ophthalmoscope and make a marking where the break is on the sclera. That's a point where we would like to support the sclera with a scleral buckle. Once it is marked, I'll be showing you the technique of implant, though this is not very commonly done nowadays, but still, as to complete the procedures, to have understanding, we will show you some techniques, and in this we are showing you the implant technique. You make flaps about 3 millimeters on all sides of that marked point here. You go at least 3 millimeters. You can go more if you have to support a bigger area, and you do the dissection with not a very sharp knife, but still sometimes you can have problem. As you can see here, the knife was slightly sharper, or you went little deeper, and or the sclera may be a little thin, and you may have an sort of popping up of the choroid there. But you can still go ahead. We managed to make a bed there, and once the bed is made, you take a sclericon band which would fit in that size. So the size is not decided beforehand. You have to keep a set of bands ready with you, and once you have done the dissection, you select the band you want, which would completely fit in that dissection you have made. And once the band is dissected, the area is dissected, you start dissecting for the encircling elements. You use again that same dissection knife to make scleral tunnels, which you do in the other quadrants where you are not going to place the major buckle. Once the tunnels are made, you place sutures. We usually use a 4-0 ethibond or a 5-0 dacron to place the sutures there, and once the sutures are placed, you pass the main buckle with the encircling element under the sutures, and then pass the encircling element all around. Once the encircling elements goes all around, your buckle is in place, then you go to the next step of drainage. The subretinal fluid drainage is usually done in the bed of the buckle, but if there is less fluid in that quadrant, then you may select sites where the fluid is maximum. Usually you prefer to do it above and below the lateral recti where the large vessels are absent. So you have exposed this knuckle there of the choroid, and then you just prick it with a 10-0 needle. You can use a laser if you have in the OT. You can use even a laser to make that opening. Once that opening is made, you gently try to squeeze out as much fluid as possible through that, and at the same time keep pulling up the eyeball and don't allow significant hypotony to occur, because significant hypotony can at times lead to vitreous hemorrhage. So once you are sure that you have drained most of the fluid, you tighten up the buckle, pull up the encircling element, and then you look inside and see whether all the fluid has been drained and the retina is flat. If the retina shows any folds, you may decide to inject either saline or gas, or even at times just plain simple air. So once you are sure that retina is flat, there are not much of problems, there is no vitreous hemorrhage, you tighten up the buckle, make the sutures permanent, and you are through. Then you come back, push the eyeball back, pull up the conjunctiva and suture it, or you can use a glue to complete the conjunctival closure. So this is the picture at the end of the surgery. Thank you. If you have any questions, Dr. Preetam will be answering them, because I will be going to the next IC. Then I think Dr. Ashish is there.
Dr. Ashish and Dr. Amit will be the last men standing.
Thank you very much.
Thank you.
Prabhu
Thank
Desai,
you.
it was a good talk. Now I invite Dr. Nishikant to give his talk.
So Dr. Nishikant is going to compare the two procedures, scleral buckling versus vitrectomy.
So I got the job of comparing both, and both of the we love both the procedures, and unfortunately with the evolution of vitreoretinal techniques that are coming through, we are finding that people are tending to go more and more towards a vitreous surgery than a scleral buckle. And today, if you compare both the procedures, it will always be a debatable thing, because we coming in from a generation which started only with buckles and then slowly moved on to vitreous surgery, versus people who started with a vitreous surgery and try to move to scleral buckle, is always going to be a difficult challenge. But many a times, rather than pitting both against each other, it is always good if we can have a combination of two procedures in many of such cases, and that can give us fantastic results. Now, why vitrectomy is being preferred? Because it has evolved a lot as compared to a buccal surgery. Somewhere the buccal surgery has just stagnated at one place. The only improvement coming in was the chandelier used buckle, which is there. We got better cutters and better vitrectomy consoles, a lesser gauge, less painful for the patient, increased comfort for the surgeons, because they really don't have to bend and break their back as much as we have to do in a buccal surgery. And it is very easy to teach when you're doing a pars plana vitrectomy, because it's easy to demonstrate, as compared to us trying to see through the teacher's mirror in the indirect. It is a very easy way to teach. But there is a big disadvantage. When you're going inside the eye, you're distorting the anatomy from inside. You have to give the positioning for the bubble, for the silicone oil. And we all know that silicone oil can lead to a lot of complications later on. If you have a pseudophakic eye, the bubble can cause an IOL to shift. We do get retinal folds and PVRs that come in. But most importantly, vitrectomy is a very less forgiving surgery. And if you leave a small hole somewhere, it's going to lead to a complete detachment the minute the gas bubble goes out, or you remove the oil. And each of us goes through the same amount of anxiety when you're seeing the patient with a gas-filled eye, and they are coming back to us. Can we go back a bit? Sorry, back. Okay, sorry. Yeah. So it is a less forgiving surgery. And again, the major drawback of a primary vitrectomy is that it is associated with a lot of functional failures. We always have a honeymoon period when you have the tamponade going on, but later on you can get complications coming in, you can get epiretinal membranes coming in. And to avoid failure, we end up having an overuse of silicone oil. I knew a lot of people who just put silicone oil and they don't rely on the gas at all, and that we know leads to an expensive surgery, and it's also cost the patient the eye many a times in form of glaucoma, etc. coming in. Now, scleral buckle is a very forgiving surgery. It does not induce cataract. It's low budget. Doesn't need many times a tamponade. It doesn't need sophisticated instrumentation. And if you have a chandelier-assisted buckle, it is a very easy to do without really bending your back. The disadvantages: it alters the shape of the globe, and then it induces sort of a refractive error and a difficult astigmatism for the patient. It can cause ocular motility disturbances, and overuse of cryo can lead to PVR. But come to us for any young guys, and all of us will blindly say that scleral buckle is the best thing to do as compared to a vitrectomy. Now, this is a 24-year-old person in whom you can see how well the retina is settled, and this type of retina, we can bet that you will never get a detachment or anything coming back, and you're not going to be really scared for these cases. So when you have a result like this with a good buckle effect and CRA patches which have covered all the holes, you're assured for the rest of the life the patient is not going to have any complications. You're not going to look out for glaucoma or anything that is induced, and this is the beauty of buckle. Now, these are just head-to-head comparisons that you see. A scleral buckle is an indirect and a passive, whereas a pars plana vitrectomy is a direct sort of an approach. And internal tamponade not nearly needed all the time, and you can get the efficacy for superior and inferior breaks are equal for scleral buckle vis-a-vis a vitrectomy, where we find superior are easier than inferior because you need a lot of tamponading, etc. But if you go to a single surgery success rate, you will find that both of them are comparable if you really do well, and that's where scleral buckle has slight advantage, where it goes to 90 to 95 as compared to 85 to 90%. And the biggest reason for that is in a scleral buckle, even if you miss a break which is in the periphery and you put a belt buckle, it is still supported on the belt buckle, and therefore it's not necessarily going to induce immediate amount of detachment. The rest of the things I've already covered in the earlier thing. Now, if you go to the indications, you can see that scleral buckle is definitely a must in younger eyes, a partial retinal detachment involving only 1 or 2 quadrants. In phakic eyes, detachments with minimal minimal vitreous changes, and detachments with a good amount of anterior retinal breaks or dialysis. When you go to vitrectomy, you would prefer it in myopic eyes with thin sclera because it's difficult to do a buckle in a very thin sclera. Posterior breaks, giant retinal tears, wherever there is a lot of traction, there's a vitreous hemorrhage or opacity where you cannot see the retina very clearly, or recurrent retinal detachments, PVR, you can't do a buckle. While vitrectomy can be performed for all indications, scleral buckle cannot be performed for the indications of vitrectomy, and that is fair and simple for us to know. So there have been a lot of studies. I'm not going to go into the retrospective studies, each one of them, but I'll just show you one table which shows that the success rate of a single surgery is nearly the same if you do both and choose the indications carefully. So you have to understand that if you are doing a scleral buckle in a very skillful way and use the correct amount of indications, your single surgery success rate is going to be as good or better if you're going to do a vitrectomy. So coming to the conclusion, there is always a controversy, and the debate will keep on going on, which is more efficacious. But I feel that in a properly indicated, a young patient with a phakic with minimal vitreous changes, single break, 1 or 2 quadrants, a very anterior break, I would still prefer to go ahead and do a buckle vis-a-vis a vitrectomy. So even if a scleral buckle is an old technique, it still holds good and gives excellent results. And therefore, it is advisable that young retina surgeons should follow this surgery passionately and try to take it ahead. Just to end, this is a small video of a case which was having a coloboma and had got a peripheral tears also. And here I have done a combination of both. The visualization was not good, so I have done a 360-degree encerclage and along with the vitrectomy. And this patient, we could easily do well, and the patient has got good responses. So many a times select your cases well, and we really don't have to pit both against each other. Combine both, and I'm sure we are assured of a good result. Thank you.
Thank you, Dr. Nishikant. Any questions for Dr. Nishikant, because he'll be leaving the session. Thank you.
Thank you.
So we go on to the next topic for the IC, and that is vitreous tamponade, gas versus oil, all the merits and demerits of the vitreous tamponades, and the speakers, Dr. Vatsal Parekh. Vatsal sir.
Yeah. Now, normally, as Preetam said, we would use in vitrectomy, primary vitrectomy, first surgery, gas, C3F8 gas. For inferior breaks or patient who wants to fly an outstation, we use silicone oil. But preferred choice is C3F8 because it remains in the eye for almost 2 months, and that is the time I think PVR is active and it gives much better buoyancy and tamponade effect. What I am going to do now is to take you through different clinical cases which I have treated, as all the basic topics are covered. Now, this was a patient who had a large horseshoe tear, subclinical detachment, and has undergone only Barad laser treatment. This was the slit lamp photograph of the same, and I think for more than 1.5 years he's conserved and he's doing well. Another patient with a large horseshoe tear and lasered, and it's more than a year and his retina is attached. So this was subclinical detachment also. So this shows the use of laser for detachment. This is after a year the retina is still attached. Now another patient who had a large tear with a more like a giant tear but little less than typical giant tear because it was not 90 degree. It was lasered well, but after 1.5 months he developed detachment with PVR and needed vitreous surgery, and we did silicone oil buccal, still had recurrent shallow detachment and is being conserved because macula is attached. So you need to follow up this patient. Now these are some of the patients of giant retinal tear. This was an inferior giant retinal tear with detachment. Now this patient has undergone only vitrectomy with C3F8 gas and no buccal, and still retina was attached even after cataract removal and IOL placement. This is another giant retinal tear which was treated with vitrectomy with C3F8 gas. During COVID time he had detachment and PVR after 1.5 months and had undergone silicone oil injection and has remained attached, but no buccal was put. Another one-eyed patient with a giant tear, only vitrectomy 23 gauge was done with C3F8 gas tamponade. Though the age is rolled here, but retina was nicely attached. Patient had cystoid macular edema but has recovered good visual acuity, and I think for more than 2 years is maintaining good visual acuity. Now this is another interesting patient who had a giant tear, rolled edges, the disc is not seen. I did 23 gauge vitrectomy with perfluorocarbon liquid and C3F8 gas. The retina was beautifully attached for almost 2 months, and after 2 months had inferior detachment. If you see here, still the this is probably after a month and a half, inferior detachment, and I did buccal. And since this was well buckled and everything was fine, I thought of putting only SF6 gas because I thought there was no PVR, so it should stay well. But probably in 2 weeks time he had another horseshoe tear superiorly, and then this was a patient with RK, and I had done already 2 surgeries, so I did vitrectomy and silicone oil injection, and the retina has remained attached. So this is how this patient went. Another patient with a large horseshoe tear inferiorly with PVR underwent vitrectomy and 23 gauge vitrectomy with gas, had shallow detachment inferiorly. There was no PVR, so I thought of putting only buccal. So here buccal was put, again had shallow detachment, so underwent vitrectomy with oil. Retina was attached, and he underwent cataract with silicone oil removal and pucker removal and has remained attached. So many times you may need multiple surgeries also. Now this was a patient who was buckled a year back, had redetachment. So we had done vitrectomy and C3F8 gas injection because buccal was already there. Then he had redetachment. This is the OCT which shows detachment below. Now I thought this break was leaking, so what I did was, since there was adequate tamponade, I have done only cryo and position given to this patient, and retina is beautifully attached without any further treatment almost since 2 months. So basically you take advantage, and I think this is the advantage of following a patient properly, because when you follow up properly, you know what is the initial pathology, and at that time just topping up gas, doing cryo or laser and giving position may avoid resurgery. That is what I am going to show you 3-4 patients. Another patient who had superior break here, detachment operated, and vitrectomy and gas. Probably after 3 weeks, when the bubble receded, he had fluid appearing again. And I thought this break was there. So again, I did only cryo to this patient and given him position, and his retina remained attached properly. Another patient who had a giant tear had undergone vitrectomy with C3F8 gas injection, no buccal. He had a lens touch, so he developed cataract. And on B scan, I realized after 1.5 months, 2 months, we were repeating B scan regularly, he developed detachment. So this patient, I did buccal, cataract, IOL, and put gas because the detachment was shallow and there was no PVR. So that worked for almost 1.5 months, and then he developed superior detachment here. So at this juncture, there was a break above upper nasal quadrant. I thought there was a break, and I injected only C3F8 gas in OPD, and the retina got reattached. And then I thought, since this side was giant tear, I did laser around buccal and posterior to buccal in this eye, and since 2 months is attached. So I think planning the treatment is important, and understanding PVR and intervention is important. Similarly, another patient, detachment, had redetachment, and I injected gas and did cryo, and retina is reattached. Now this patient had buccal removal, and following buccal removal had detachment here, which was lasered to barrage it, but developed redetachment. So I did vitrectomy with gas, and following that he had detachment here, and through the peripheral OCT we could see the break here, and through the view there was a break here, so I did cryo and put top up gas. The retina got reattached. As you see the OCT here, the retina is attached. But again, he has got detachment, and this we have taken series of photograph, and you know now that this is because of the PVR which has set in. There is early fixed fold. So probably he would need another surgery with oil. So this helps us to understand the pathology. So basically, I think fresh detachment with giant tear should be managed promptly by vitrectomy, and normally I prefer without buccal because there is no PVR. Good follow-up and careful understanding of recurrence is important in planning out treatment, because many times you may be just able to top up the gas C3F8 and get out of the problem. Pneumoretinopaxy can be done in select redetachments, as I showed you, with superior breaks or up to horizontal meridians, and doing cryo at that juncture through the gas bubble or laser may be sufficient. PVR is the biggest cause of redetachment, and timing of surgery is important. Thank you.
Thank you, Dr. Vatsal Parekh. Any questions for sir? Okay, I think then with that we go on to the next talk. This is a keynote address by Dr. Amit Kumar Deb. Anti-VEGFs, what's new in the armamentarium? Dr. Deb.
Very good afternoon to one and all. So my topic is slightly unrelated to the current IC, but nevertheless a very relevant topic for the day-to-day retina practice. So at the outset, I would like to thank AIOS Scientific Committee to provide me with this opportunity to present this talk and be on the dais with all the distinguished speakers. So I have no relevant financial interests to disclose. So anti-VEGFs are the mainstay of treatment for various retinal diseases, including neovascular AMD, DME, and RVO. There have been considerable advances in the field of posterior segment pharmacotherapy since the first anti-VEGF molecule, pegaptinib, was launched. Subsequently, multiple biologics have been approved for intraocular use. The recent innovations in the field offer better treatment efficacy, longer interval between treatments, and higher quality of life for the patients. So about angiogenesis and its regulators. So vascular endothelial growth factor is the major plays the major role for angiogenesis. We have other cytokines like fibroblast growth factor, platelet-derived growth factor, integrins, and angiopoietins also. So VEGF is of 5 types, A, B, C, D, and E, of which VEGF-A plays the major role for angiogenesis. There are various isoforms of VEGF-A, of which VEGF-A 165 is the pathological isoform. Coming to the VEGF receptors, there are three types of receptors, of which VEGF receptor 2 is the major mediator for angiogenesis. The VEGF inhibitors act either by prevention of secretion of the molecule, direct emission of the molecule in the extracellular space, blockade of the receptors, or interruption in the downstream intercellular signaling pathways. The anti-VEGFs which are commonly used include mostly Renewabism and Bevacizumab. So these two drugs have demonstrated good efficacy with visual gains of at least 5 to 10 letters in the treatment of various retinal diseases. However, they need monthly injections, and the newer agents offer longer drug durability. Injection interval can be increased to 2 to 3 months also after the initial loading doses. So what are the longer acting anti-VEGFs? The commonly used one is the aflibercept, which incorporates the second binding domain of VEGF R1 receptor and the third domain of the VEGF R2 receptor. It penetrates all layers of the retina. In VIEW1 and VIEW2 trials, it is seen that aflibercept dose monthly or every 2 months produce similar efficacy and safety outcomes as monthly Renewabism. A similar drug, which is the Convacept, was approved by China FDA in November 2013. So one minor difference with aflibercept is that it contains the additional fourth binding domain of VEGF receptor 2, which is essential for receptor dimerization and enhances the association rate of VEGF to the receptor. So what are the newer anti-VEGF drugs, which are the longer acting ones and those under investigation? So we have abacipar-pegol. All the available anti-VEGF agents are based on antibodies or their fragments. So advances in bioengineering technology have led to development of designed anacrin repeat proteins or DARPins. They bind to all the VEGF isoforms and they have high specificity and affinity to a selected target. So their affinity is more than Renewabism, also a longer intraocular half-life compared to Renewabism. The phase 3 study of the drug has shown visual improvement and non-inferiority to monthly Renewabism with fewer injections, and the injection interval could be extended to 12 weeks. So these are phase 2 and phase 3 trials for abacipar-pegol. So although they have achieved non-inferiority in terms of visual gain and reduction of CRT compared with Renewabism, the rates of intraocular inflammation noted were considerably high, 10% in the REACH study, 15% in the CEDAR and SEQUOIA study. So this drug has not received FDA approval yet for this intraocular inflammation. Next, we have dual target therapeutics or faricimab, which is the latest addition in the family of anti-VEGF, which has been approved for wet AMD and DME in Jan 2022 by FDA. So it acts by inhibition of angiopoietin 2 as well as VEGF-A. So these are phase 3 trials of faricimab in neovascular AMD as well as in diabetic macular edema, the TNIS study, Lucerne, Yosemite and Rhine studies. So what is important to note here is, in these trials, about 50% of the eligible trial patients were able to go 4 months between the treatments within the first year, and up to 75% could go up to 3 months between the injection periods. Next, we have the Renewabism port delivery system. It is a small refillable eye implant that continuously delivers Renewabism into the eye. So this 2 milligram reservoir of Renewabism port delivery system maintains therapeutic range of the drug up to 6 months after the implantation. So the phase 3 trial in neovascular AMD is the AIOC study, where it has been seen that almost 98% of the patients in the study did not receive any supplemental treatment or injection before the first refill or exchange. So this RPDS has achieved FDA approval for the treatment of neovascular AMD in October 2021, and studies in DME, the Pagoda study, and diabetic retinopathy, the Pavilion study, are currently ongoing. However, few adverse events are noted with that implant, like few incidences of endophthalmitis, rhegmatogenous RD and vitreous hemorrhage, and also few instances of implant dislocation. Next, we have the brolucizumab or Pejanax. It is a single chain antibody fragment and autonomous binding agent that is no longer dependent on a heavy molecular support structure and still retains its full binding capacity. And advantages are, it has effective tissue penetration and administration of more drug in a single injection. So July 2019, it had obtained FDA approval for neovascular AMD, and just 3 days ago, it had got FDA approval for DME also. So brolucizumab has more VEGF binding ability per volume compared to aflibercept and other agents, and it is engineered to deliver more drug per dose. So these are the 2 phase 3 trials, Hawk and Harrier studies on brolucizumab, where it has been compared with aflibercept. So the vision-related outcomes have shown that brolucizumab was non-inferior to aflibercept for the mean change in BCVA at week 48, which was the primary endpoint. It was maintained till week 96. Also, the anatomical outcomes, it has shown superior reduction in CST at week 1648, and this was reaffirmed at week 96 in both the studies. Also, the fewer patients on brolucizumab had intraretinal fluid or subretinal fluid at weeks 16, 48 and 96. So this is one important finding, the sub-RPE fluid, which is not addressed by most of the anti-VEGFs. In this study, it was seen that brolucizumab was able to address that, and at week 16, 48 and 96, fewer patients had sub-RPE fluid. Also, more than 50% of the patients on brolucizumab were able to maintain every 12-week dosing until week 48. So this is one of our patient who was diagnosed with IPCV, polypoidal choroidal vasculopathy, and after one injection, we can see she had substantial reduction in the subretinal fluid. Also, the PED height has reduced, and after second injection, we can see the subretinal fluid has completely disappeared, and only a small minimal PED is there, and she is due for the third injection. This is another gentleman who was diagnosed with CNVM, and he was given brolucizumab injection. 1 week after the injection, you can see good improvement, and at 1 month, complete disappearance of the SRF and IRF, and he is also due for his second injection. However, there are some concerns with the ocular safety profile of brolucizumab. Within 1 month post-marketing, there are incidences of severe retinal vasculitis and anterior segment inflammation reported. So in this case, we can see a minimal occlusion in the infratemporal retinal arteriole 2 months after brolucizumab injection in one of the patients. This is another patient who had developed occlusive vasculitis 24 days after brolucizumab injection. This is another patient who had developed severe occlusive vasculitis and grade 3 vitritis 2 months after brolucizumab injection. So mechanism for this IOI and retinal vasculitis are multiple theories. The most common ones are the more potent anti-VEGF effect of brolucizumab compared to other anti-VEGF agents. Also, anti-drug antibody, which is a type 3 hypersensitivity reaction. Almost 50% of the patients had pre-treatment anti-drug antibody levels with Pegenax compared to less than 5% with other anti-VEGFs. So this ADA is responsible for occlusive vasculitis. So role of ADA should be evaluated in future clinical trials. So last but not the least, we have the biosimilars, which are large molecules that are developed by modified cellular processes. So they provide safe and lower cost options for the treatment of retinal diseases while providing equal efficacy. So some of the biosimilars available in India currently for Renewabism are Resumab, Visumab, and Renusural, and also aflibercept biosimilars are there in various trials. So these are two of our patients. The first patient had developed CNVM, and following 2 injections of Visumab, we can see the IRF and SRF has disappeared, only a small Dusonate PED is persisting. Another gentleman was diagnosed with diabetic macular edema following a single injection of Visumab and IVTA. You can see normal foveal contour almost with all IRF and subretinal fluid has disappeared. So to summarize, the anti-VEGF medications have been revolutionary for treating retinal diseases, but there are still various unmet needs like burden of repeat injections, the cost burden, immunogenicity of the newer agents. So to address these unmet needs, there is still research ongoing to improve the outcomes in the retinal diseases. Thank you.
Thank you, Dr. Deb. Any questions for Dr. Deb? Okay, Dr. Deb, what do you think would be the future, let's say in 2025? What would we be using in 2025?
The multiple other therapies coming up. Gene therapies is in the line. So we don't know, every year some new treatments are coming. So faricimab is the one which looks very promising. Even the brolucizumab has been approved for DME just 2 days ago, FDA approval. So as far as my experience with brolucizumab, we have seen good results. And also the biosimilars, now because the US patents and European patents are going to end by 2023 for all the drugs. So Indian market, we can expect some more biosimilars to come in, and they will help to reduce the cost burden for the patients. So all these aspects we'll see. So newer drugs are still in the pipeline.
Yeah, so the newer drugs will provide 3 things, I think. They will provide you with greater efficacy. The interval between the 2 injections would be longer.
Almost 4 months with faricimab and 3 months with brolucizumab currently.
Yeah, and hopefully the cost would be lower. Okay, now I'll take my last talk. So I'll take my last talk and conclude the session. So let's. Yeah, so I'm going to talk on intraoperative change in the plan when we are doing a retinal surgery. So retina has multiple choices for treatment. You can go this way, you can go that way, you can go the other way, and hopefully we all land up still in the same situation. So when you do a preoperative examination, it is extremely important that we consider all the factors that are there, and it's very important that we make the right choice and not the wrong decision. Till the 20th century, retinal detachment was equal to sterile buckle. PVR D1, D2, D3 were only, we used to do vitrectomy for that. But what has changed? There has been a paradigm shift in the vitrectomy. You have advent of small gauge vitrectomy. It is a procedure of choice in pseudophakic eyes. In procedure of choice in phakic eyes with PVD would be may still be a vitrectomy. Posterior breaks, it gives rise to better cosmesis, and there are no recurrent episodes of redness and infections once the treatment is successful. So buckle in the modern era is more of an exception than the rule. It is usually only done in peripheral breaks in young phakic patients. Any patient who is a pseudophakic, I would tend to err more on the side of a vitrectomy. So what are the indications for intraoperative conversion? Like suppose I am doing a buckle and I want to convert intraoperatively to a vitrectomy. Now there are posterior breaks which are pre-existing, or the posterior break may happen due to a perforation and I may not be able to tamponade to block that break. So I would convert to a vitrectomy. Large amount of residual fluid after drainage. Bleeding from drainage site which may be either subretinal or a vitreous hemorrhage. Or there may be PVR or subretinal gliosis which prevents apposition of the break on the buckle. However, one must remember that a buckle is a very forgiving surgery. There are many times when rather than going in at the same sitting, we may decide to come out to just keep the buckle, see the patient again, maybe a couple of weeks or a month down the line, go in and do a vitrectomy and achieve again a good result. There's also a little medico-legal dilemma because you are telling the patient that you are going to do a buckle and then you end up doing a vitrectomy, and a vitrectomy will have other complications, like in a young patient there will be definitely cataract will be accelerated in these patients. How about vitrectomy change to buckle intraoperatively? Usually, as I said, if you have a good preoperative evaluation, this does not happen, but a good preoperative evaluation may not be possible, especially in the pediatric age group. And hence, if a detailed examination is done under anesthesia and the surgeon feels that a buckle would be a better choice, then we would change from a vitrectomy to a buckle intraoperatively. Then we go to addition of a buckle to a vitrectomy procedure. This can happen in patients who have inferior breaks, peripheral unrelieved retinal contracture, and sometimes if you want to support the vitreous base, then we may add a buckle to a vitrectomy procedure when preoperatively we have decided to do only a vitrectomy. So in the end, we all need to make the right decision. Remember, what happens in the operation theatre is known only to the surgeon, similar as to what happens in the battlefield. Only the soldier who's fighting over there knows what happens. It's very difficult to dissect that decision, what the surgeon has taken afterwards, in the hindsight of the result. You know, once the result comes as not detached, then we would feel, oh, maybe, I should have done a vitrectomy, or I should have added a buckle, or I should have done something else. But this happens only in hindsight. So the right decision is a decision which is taken on the operating table, and this is a tough decision to be taken. But if you take the right decision and a tough decision, then there are various solutions which can happen, and all of them hopefully would lead to the same site, and that is a well-attached retina. So at the end, I'm going to just put a summary of the retinal detachment studies 6 reports. In the first report, it describes the overall methodology, and all 3 procedures, that is a scleral buckle, a pars-linear vitrectomy, and a pars-linear vitrectomy with either a belt buckle or a sterile buckle, have a very high single surgery anatomic result of almost 90% or above. Now, if you have to compare the two, then in phakic patients, as the study 2 shows, in phakic, it is not showing. Okay, anyway, as the second report shows, is that in phakic patients, sterile buckle shows the best visual outcome compared to the other patients. Now, what about pseudophakic patients? Study report number 3, it compares the anatomic and visual outcomes of the pars-linear vitrectomy versus PPV versus sterile buckle. Eyes undergoing PPV with scleral buckle had a higher rate of anatomic success, although the vision outcome was the same in both the studies, both the patients. In the study report 4 shows the effect of 360-degree laser. Some of us do 360-degree laser, some of us do laser only to the retinal hole. So this depends upon younger patients, surgeon preference, number of breaks and extent of the detachment. However, 360-degree laser was associated with worse anatomic and visual results. Maybe this could happen because there was more extensive breaks, so the surgeon decided to do the complete laser, or maybe the laser gave rise to more PVR, or sometimes gave rise to more epiretinal membranes, or there can also be problems with the laser, like you can have the long ciliary nerves getting affected and corneal decompensation. The next one was to evaluate the anatomic and visual outcomes of non-complex rhegmatosis retinal detachment when using non-contact versus contact systems. And again, anatomic success rates was similar using either of the systems. And the last one was to compare the anatomic and visual outcomes between primary PPV and PPV with plus sterile buckle for inferior retinal breaks. And for this, retinal detachment with inferior retinal breaks had a very high single surgery success rate if you treated it with PPV with a sterile buckle. So you can either put a 240 band or you can put a sterile buckle down inferiorly to support the inferior retina, give rise to a larger anatomic success rate. However, the difference in the anatomic success rate was more prominent in phakic eyes. So these were the 6 reports of the PRO studies. Thank you. Any questions? So I think with this we conclude the IC. Thank you very much.